rolling. I'll pull my desk over here and get myself organized. Okay, so neurological assessment. We're going to today have you pretending that you have symptoms of left-sided weakness. Okay, that's the only thing, and a headache. Okay, that's all that we're going to be going through. We're going to make you a 56-year-old male that had these sudden onset. You can make up the rest or be healthy. It doesn't make any difference to me as we're walking through, and I'll try to follow along. I'm going to try to follow the sheet, and then I'll, in the demonstration, do it a little bit more organically. That's not quite following the sheet by script. Okay. So, hi, my name's Matthew. I'm a paramedic. What's going on today?
I'm Matt too. I have a bit of a headache.
Okay.
Thing, yeah. And I don't know. It feels like I'm favoring my right side a lot.
Okay. So when did this start?
Just a few minutes ago, really.
So obviously he's alert. He's succinct in his answers. His airway is protected. He doesn't seem to have dyspnea. And just feel your pulse for a moment. A nice strong radio pulse. So you were telling me what was happening. Sorry, before I rudely interrupted you. When did this start?
About 10 minutes ago.
About 10 minutes ago.
Yeah.
Okay. What were you doing when it started?
I was lifting a box we're moving soon, and I just kind of like fell over.
Oh.
My hand started hurting.
Okay. Have you ever had anything like this before? Okay. You don't have history of headaches or anything like this typically? No, never sought medical attention for any neurological condition, for migraines or... Of course she does. She must hang out with my wife. I didn't mean it, dear. I still would like chili tonight. Okay, so anything seem to make that headache better or worse?
Just laying down in the dark room.
Okay.
Seems to be okay.
Could you describe it to me? What's the pain feel like?
It's almost like a pounding.
A pounding?
Yeah.
Okay, kind of throbbing with every heartbeat you feel it? Okay. Is it what kind of number would you give it? If 10 being the worst headache you've ever had and 0 being none?
7.
7? Okay. And is it fairly consistent?
Yes. That's what I'm saying.
And did it come on right away? Did it start, was it like a light switch, like you turned it on and all of a sudden you had a 7 out of 10 headache, or did it just gradually get worse?
It kind of built up a bit.
Built up a bit. Okay. Over how long did it take to build up? Just
a few minutes.
Just a few minutes, because it just started 10 minutes ago.
Yeah.
Okay. If I'm understanding correctly, headache started 10 minutes ago. Never had a headache like this before. It's pounding, and severity 7 out of 10. Is that what you said? Just a bit your past medical history. Do you have any allergies?
No.
Do you have any medications?
Flintstones gummy vitamins.
Oh, fantastic. It's not them. Do you have any past medical history at all?
No, not really.
No chronic health problems? Have you ever been told you have epilepsy or have migraines or nothing like that? Okay.
My sister gets migraines though.
Oh, okay. So have you ever had, are you not prone to really bad headaches? No, not like this?
No.
When's the last time you had a headache?
Probably 2 months ago, maybe.
2 months ago?
Yeah.
And what number would it have been?
5.
A 5 or so? And how did you manage that?
I just lay down, kind of.
Lay down? Take any Tylenol or ibuprofen? Or no, just went to lay down, went to bed. Okay. But didn't have any weakness at that time?
No.
No. Haven't noticed you had dizziness or difficult seeing?
A little dizzy, yeah.
A little dizzy? Any blurred vision that you're noticing? Are you able to see things pretty well?
No, I see pretty well, I think.
Okay. We'll check that out here in a moment. So that's kind of the symptoms that I can think of. Headache. We talked about weakness, dizziness. He hasn't had any syncopal episodes or any fainting things. Any history of heart problems at all? Okay. Ever been told that you have, never been told you have angina or never had a heart attack? High cholesterol? No. Do you ever feel like your heart's racing or skipping beats?
No.
No. Never been told you have any heart arrhythmias, anything like atrial fibrillation or anything like that?
I don't know what that is.
Okay. Any problems with your lungs?
No.
No. Don't find you're getting short of breath with small amounts of exercise?
No.
And because he's complaining of head pain, there's not a lot, like these systems don't interact very well. Like heart pain doesn't cause head pain, right, with weakness on one side. So he's complaining of very specific neurological symptoms. So you're noticing around the chest, I'm being very skinny around my diagnosed conditions, my symptoms, and my risk factors. Now, I didn't go through risk factors for neurological, and I'm realizing that now. Is it okay if I go back and do my risk factors? Because I did diagnose conditions and symptoms and risk factors, and I said I was going to follow the script and not be kind of organized and let the conversation flow. But I'll walk through, I'll try to stay to the script so you get it in the order that I've given it to you. Do you have a history of diabetes?
My great aunt.
Great. Do you personally don't have diabetes? Are you a smoker? High blood pressure? We already asked whether or not you have high cholesterol. No. So I can see that he's not obese. How active would you be in a day? How much time in a day would you spend walking or doing exercise?
Really depends on the day, but half hour.
Okay.
Walking.
Okay. You've already told me that you have no history of angina or any coronary artery disease. Any difficulties with circulation in your extremities, in your feet? Haven't had sore legs or anything in the last few days? Have you been traveling for long durations or anything like that? Okay, so no, we're not thinking a risk of for blood clots. Okay. Do you drink alcohol? Okay. Have you been stressed lately?
Yes.
Yes. How do you normally feel when you get stressed? Do you get headaches when you get stressed, or what do you feel?
No, just I don't know. Just deal with it fairly normally, I guess.
Normally. What do you deal with when you get stressed? What kind of? You just feel kind of pressured. You don't get any physical manifestations of it. Okay. So he's not an oral contraceptive because he's not female. Polycythemia and sickle cell anemia and deficiencies in clotting. So you've never had a problem with blood clots, no? Okay. Those are all conditions that could lead to bleeding or blood clots. If he doesn't have a history of those, he's not going to know about them. Right? Okay. So just ask him, do you have any history of bleeding or blood clots anywhere in your body? Then we would know about that. I did neurological just to kind of bring me back to where I was in this, because I said I was going to follow this, and I'm trying to. The neurological diagnosed conditions, symptoms, and risk factors. Then I went cardiac diagnosed conditions and symptoms. Risk factors are the exact same as neurological. The vasculature is the same thing. So if you've had a heart attack, you're much more prone to have a stroke. Or if you have a stroke, it's the same vasculature, right? For the ischemic type, the clotting type of stroke, not the bleeding type of stroke. So there's some bleeding things in here that wouldn't be in a heart attack, okay, or in cardiac risk factors. Then I asked him about lungs and symptoms. He's not on any home oxygen. He's not a smoker as far as those risk factors. As far as abdominal cavity, I'm just going to ask diagnosed conditions in generality and really not dig in that deep, because this is not related to. He's not having abdominal pain. He's not even close to a region, because I did region below. Fairly indeed. So I did cardiac and respiratory for diagnosed symptoms and risk factors. And now with his abdomen, I'm just going to say, how's your appetite been lately?
Pretty good.
Okay. Haven't had any nausea or vomiting? No problems with your stomach or esophagus? No. How bowel movements normal? Okay. No changes there. What about urination? All normal. Haven't noticed any pain in your arms or legs lately? And then we'll be done as far as past medical history. So it was really detailed head, region below, really detailed, and just kind of skimmed the major things here. Does that make sense why I would do that?
Yeah.
And then up to last time you were to your family doctor?
Probably this summer.
This summer? Any ongoing medical tests or waiting for any medical tests, any blood work? Nothing like that? Okay. How have you been feeling in the last 24 hours?
Well, besides about 10 minutes ago,
Fine, nothing different, nothing out of the normal whatsoever until 10 minutes ago when this headache started. So now we're on to Cincinnati Stroke Scale. Cincinnati Stroke Scale is for a screening tool to decide whether or not somebody is likely to have a stroke. It's not like all medical tests. It's not perfect. I like to think of medical tests like a fishing net. Sometimes so there's some things that can happen with a fishing net when you cast your net to catch a stroke. Is sometimes you cast and the net has too big of holes, and some of the stroke patients get through, so you don't catch those fish and you were wanting to. And also, you end up catching some fish that you didn't want because they also get caught in that same net. So there's two ways that they're called sensitivity and specificity. Sensitivity is whether or not you catch the stroke. Specificity is how many fake strokes do you catch, right? Do people that you caught in your net, but they're not having a stroke today, right? So every medical test, and the ideal test would be have 100% sensitivity, 100% specificity. And there are some medical tests, and then there's lots of tests that we use that have a range, okay? This one that we're using today, I don't know what the specificity is, or the sensitivity. We know that if you have these symptoms, that it's specific. I guess I do know the specificity. I can't say the word. Maybe I shouldn't. Is that 80? So it says 85% of patients that have 3 of these symptoms are having a stroke today. If 85, so if you have all 3 of these things, then you're 85. If you just have 1 of 3, it's 72. You don't need to know that. Just interesting to know. It's not a perfect tool. Sometimes you catch people that aren't having a stroke, and you don't catch all strokes. That's important to know. So this is not the only screening tool for a stroke. Okay? This is just a simple one, okay, that catches the big ones. Okay? So it's based off 3 criteria. The first one is facial droop. So we get them to give us a big, goofy smile, but you have to do it too. So everybody give me a big. Okay, so when we're looking, and now you have to have a mind to see, okay? You can stop now. You're smiling. No smiling. This is not a friendly place. Thank you. Thank you. I appreciate that. This is much more like a military school.
Yes, sir.
Yes, sir. Very well. Okay, so when we say that we have to have a mind to see, just like with skin color, and we can miss grossly. We talked about jaundice and how somebody can be yellow, and you can be around them for like 15 minutes, or maybe a whole encounter, and then somebody else says, "Oh my, they're jaundice," and you're like, "Oh my goodness, they're yellow, right? So of course they're jaundice, but I didn't see that." So you have to be very observant when you're doing these things and actually know what you're looking for. So we're looking for both movement, symmetrical movement, and muscle tone in his face when he gives us a big goofy smile or shows us his teeth. So if you give me a big smile and show me your teeth, I see symmetry of his entire face. So I go down forehead, cheeks to jaw, and I see perfect symmetry. Okay? Important to do. Not just look one side or the other, look the whole thing right down, because that trigeminal nerve wraps around like that. Okay? Like something like that. Okay? Comes up and innervates jaw, around your mandible, maxilla, and or zygomatic arch and into your forehead. Like so. So we're looking for symmetry throughout everything. Okay. The next one is we get them to say a phrase that's rather difficult to say. It can't be something that they're saying every day, right? They can't say hi, right, or say hello. Can you repeat after me? Hello, right, or yes. They might be able to say simple words like that. But if you tell them a phrase, the one that's often used is the phrase, "You can't teach an old dog new tricks." Can you repeat that phrase?
You can't teach an old dog new tricks.
Okay, so it takes some thought process and very deliberate to be able to use, and that it involves a number of cranial nerves to be able to speak. And the things that can be diminished. So his left-sided weakness, right, as we're thinking a neurological problem, this could either be the muscle, it could be the nerve, or it could be rooted actually a problem in his brain. Okay, those are the big generic areas that we could have problems. And there's not going to be any way for us to tell in this situation between those things, if it's a muscle or a nerve or a brain. We can talk a little bit more into, there's some aspects, but in gross things, it would be hard to tell. So the last thing is what's known as an arm drift, sometimes called a pronator drift. Get your hand, a patient put their hands out in front of them, hold their hands in and close their eyes. Okay, so I'm just going to hold your palms up, arms straight in front of you, close your eyes, and we're just going to hold his hands there for 10 seconds and wait the full 10 seconds. So what will often happen if he's got weakness on his right side is this hand will start to drift slowly. Sometimes they won't be able, and it might just go to here, right? And they'll open their eyes and they'll go, oh, and they'll move their hand up. But that means he's got weakness on this side, okay? Okay, you can let your arms down. Sometimes they won't be able to move anything, and obviously we don't need to do that. To say, move your arm, hold one hand out here. We're comparing symmetry. If they can't move this arm, then we already meet the Cincinnati stroke scale. We know that already. So 3 criteria, all of which are rooted in cranial nerves, and we're going to see these other things in motor and sensory in the rest. So cranial nerves and motor and sensory that we're going to continue on. But that's just kind of 3 big ones that they're looking for to see, does this patient likely have a stroke? So if you picture where I'd be in my call, I came in and introduced myself. I delegated my partner, go get me a set of vitals. They're doing some stuff while we're talking to the patient. I talked through what was going on today, a bit OPQRST. Then I went to ample. Then I go to Cincinnati stroke scale because I'm trying to decide, do we need to get going to a stroke center? Okay, because we don't treat strokes pre-hospitally because we can't tell the difference between an ischemic, one that's caused by a stroke that's caused by a clot, or one that's caused by bleeding. Right? Can you see that if I give you a drug that breaks down clots could be problematic for a hemorrhagic stroke or one that's bleeding, right? So they need to go to a center that has CT and MRI, okay, and needs to have a neurologist on call, okay? So here in Prince Edward, we go to QEH or to Prince County Hospital. It's the 2 places that we go. So after we do after we have done our Cincinnati stroke scale, we find a positive finding, we're just going to scoop ourselves up, move ourselves over to the truck, and then transport. If it's 5 minutes away, we want to give the hospital notification. And there's some other things that we're going to do around treatment, like start some IVs and get them ready for care there. We might not get to this targeted neurological assessment at all. But if you're 20 or 30 minutes away, you might do this neurological. If you're 40 minutes away, you might do this twice. And this is very helpful for the emergency room physicians who are trying to make the decision of whether or not to give this drug to the patient. Now, with strokes, it's very interesting. Thrombolytics for strokes is controversial. Currently, it's the standard of practice that's recommended. But the thing is, this is a very rare event. We will actually today, if he's having a stroke, and they find it on a CAT scan to not be hemorrhagic and most likely ischemic, so they're looking signs of bleeding or any kind of abnormalities that would be likely to cause bleeding. If he's having a stroke, we will then give him so they will give him thrombolytics if they think it's an ischemic stroke. But that actually increases his chances of dying today. Does that not seem weird? We're going to give a drug to him today, and it increases his chances of dying. It's one of the few things in medicine, emergency medicine, that we do that increases chances of dying. But the benefit, they do this cost benefit of saying, okay, well, he may get, if he was completely hemoparalysis, so couldn't move anything on the left side of his body, they give him this drug, it increases his chances today, but it also increases chances that he goes back to full normal life as he had it before. So actually make that decision, actually explain that to the patient, that you could die if I give you this drug. Okay? So it's very rare that we do that. But can you see that the emergency room physician really wants to know how severe this is? Is this improving? Because the only difference between what's called a TIA, or a transient ischemic attack, or a CVA, a cerebrovascular accident, it's a terrible name for a stroke. That's the medical name for stroke. I don't know how it became a cerebrovascular accident. Who collided? What accident? I don't understand. So anyhow, that's what the name is. We're not changing it now. But if symptoms are improving, if they were bad originally, when you do your neurological assessment, the physician goes ahead and does their neurological assessment, sees improvements. You can see them, they might go, not giving you drugs, right? We're going to see you improve. Maybe you have some weakness on your left side, we'll send you off to physio, and you'll improve that, but you won't die today because you give you a drug and you bleed in your head, because that's a known thing that can happen. Does it happen to every patient? No, but it's a high percentage. Not high, like I can't remember if it's 5 out of 100 people that give it will die from it. Like it's quite substantial, right? We take the people, everybody in the paramedicine program, and say, okay, everybody's going to get this drug today, and 5 of you are going to die. Who's going to sign up, right? So the justification is what the symptoms are, right? So absolutely sign me up if I'm paralyzed on one side and can't move and won't be able to live life as I normally have, I'll risk, I myself personally, I'd be willing to risk dying today to get that back. Okay? So, but that's really important information. That's why we're doing this cranial nerve assessment, is it makes a great difference in the patient for them. Okay? That whether or not it gives the information to the physician, helps them to make the right decision. Okay? So, cranial nerve assessment, you're welcome to use reference when you're doing this cranial nerve assessment. I don't want you to read it. This wouldn't be like, so just glancing would be fine for cranial nerve. And I'll try to follow along once again with this sheet. 3 things that you need to do cranial nerve assessment. A blunt needle that we have in an ambulance. A blunt needle, so it's not meant to poke you. Okay, so it's kind of like a tack. It's not even that sharp. I don't know, maybe safety pin. It's not real sharp. A blunt needle, so we'll use the sharp end. We'll use that side for dull, and then a 2x2 to assess whether or not they can feel soft, okay, or light touch. So as we're going through, the other thing you grab is an alcohol swab, because we can use this for something to smell. Okay, so so we're just going to go through these one at one. So we're starting cranial nerve 1. Can you just tell me what this smells like? Alcohol. Okay, it smells like alcohol. Okay. So visual acuity, we can have our patient either read something that we can easily read at 16 inches, or you can download an app on your phone or whatnot, the Snellen chart. You've used the chart that for your eye testing with the big E at the top. I don't know what the other letters, but for whatever reason, E was the letter that was chosen for the very top. So, or you can just grab something like a 2x2. Can you just read the top line there? You go ahead and hold it, so I'm not shaking.
Non-woven sponges, sterile.
So he's actually more like 18 inches. So he's actually got good vision right now. Okay, so yeah, you don't have to, but they shouldn't be here, right? So normal reading distance away, right? If they're like, you can see that this is seemed abnormal. You can read it at normal reading distance away. Now with corrective lenses, right? So I can read this, but not there. So it depends on how their eye vision is. And as per normal, what is their vision normally like? Right? So be only important if they notice a difference. Visual fields. Okay, I'm just going to hold my hands on either side. And I just want you to tell me which fingers are moving. Okay, I'm just going to hold them out like this. Okay. So we see that his visual fields are intact. Then we're going to go to pupils, which will seem familiar. We're looking that pupils are equal and reactant to the light and consensual, which means I shine a light in the right, and the left eye, which does not have light in it, constricts. And the opposite, shine a light in the left, and the right eye constricts. Okay? So just look at my nose. I'm going to shine a light in your eyes. So looking at his left eye, looking at his right eye, looking at his right eye, looking at his left eye. Okay? So 4 times shining lights in your eye if you're doing pupils appropriately. Lots of people don't do them right. Please do them right. Okay? So we see the pupils are equal reactant to lights, constricting with pupils. We'll do eye accommodation. So watch that eyes are moving symmetrically. So we're going to do our cardinal gazes and also see that he has convergence, that his eyes are working together. And then as we bring his eyes into to make him cross-eyed, we're going to see that his pupils will constrict a little bit as we make him cross-eyed. Okay. So I'm just going to get you to follow my finger. Keep your head still and just follow my finger with your eyes. Now, while I'm watching his eye movements, once again having an eye to watch, see that his eyes come together. And then we'll also notice, you have to be observant, really observant to watch and see if pupils constrict. It's not as obvious as shining a light in his eyes. Okay? His eyes. The thing when we're following cardinal gaze, we want to watch that he has nice, smooth, concentric. Both eyes are moving together. Nice convergence. The both eyes are moving together, and should be smooth movements. Sometimes, like if there's somebody that's intoxicated, so not like crazy intoxicated, like 4 or 6 beer depending on body mass and whether they've eaten anything or not. But if you follow their eyes over to the side, you get to the lateral portion of their visual field, and their eyes will do this. Okay, it's called nystagmus. It's gaze-directed nystagmus, so they look over to one side, and then all of a sudden their eyes are going and that's an abnormal finding, which we'd want. So nice smooth eye movement everywhere as we go. And as we move in, watch that his eyes come together equally, and that his pupils will constrict as he comes in. Okay, we're on to trigeminal and facial nerve. So we're going to check here in his forehead of what he can see, in his forehead. And so both dull and light touch. So I'm just going to touch on your face with something soft, just like that. I'm going to touch with something dull, just the back side of this, and just the back side of this pin. I usually use the word pin rather than needle. People, so they don't feel like, so they're like, okay, I'm not going to get stuck with it. Okay? I'm going to get you to close your eyes, and you let me know when you can feel something. So I'll usually start off light, go dull, then to pin. Doesn't make any difference which direction you go. Okay, just tell me when I touch you. The other thing you'll notice is that his corneal reflex is intact. As soon as I touch anywhere on his face, because of his trigeminal nerve, he's going to blink. Okay, we're going to see corneal reflex intact. So as soon as I know, so you're like,
No.
okay.
No. Yep.
And you can actually see that he's feeling that by his corneal reflex, right? If you blink, blink, blink. Okay, so that was light touch. He was able to do light touch. Just going to touch her with the dull aspect.
Yep. Yep.
Okay, once again with the pin.
Yep. Yep. Yep.
Don't poke somebody's eye. Please don't poke somebody in the eye. Okay. Be thoughtful about this. Don't stick a pin in somebody's eye and blame me. It's on camera. It's not my fault. I told them, don't stick a pin in somebody's eye on a bumpy road. I also, I'm holding fairly close to the pin, right? Make sense? Controlling that well. So we see that he has full intact sensation in his face. Now we're going to go to movements, okay? Sorry, Matt, I got you walled in there. Okay, just push that one stretcher.
Yeah, I'll figure it out. I got in, I'll get in.
I walled you in. Good morning.
You better feel bad about it.
I do feel bad about it. So we're going to have some movements in his face. So we did sensation, and now we're going to do movements. So I want you to, I'm going to get you to bite your teeth together really, and I'm going to push and feel the muscles in your jaw, okay? So it can feel his mastoid muscles are equal, okay? They're equal muscle contraction in both, okay? Then I'm going to, after I do his jaw, I'm going to get him to raise his eyes, close his eyes, raise his eyebrows, close his eyes tightly, and we've also got him to show his teeth, and then we're going to get him to puff out his cheeks, okay? We've already done Cincinnati stroke scale, so I don't need to get him to do that again. You could, if this is considering this is some duration later, okay? So can you raise up your eyebrows like this? Okay, close your eyes together really tight. Okay, look for symmetry. Okay, that's good, thank you. Can you show me your teeth really wide? Okay, now can you puff out your cheeks like a monkey? And don't let me push them in, okay? Okay, so we've seen that he has muscle tone in his face everywhere. Nice and symmetrical. I'm going to stay with his mouth. I'm going to skip cranial nerve 8 for the time being and just stay here, and then I'll go to hearing in a second. So I'm going to get him to do 3 things. I'm going to get him to open his mouth and go, ah. I'm going to watch his tongue is symmetrical, midline. So I'll get him to stick out his tongue firstly, and then I'll get him to say, ah. So I'll look at his tongue, see that it's symmetrical on one side, that it's not going to one side or the other. And then then I'll get him to say, ah. I'm going to watch all of his soft palate and that uvula, that punching bag in the back of his throat, that moves symmetrically. It doesn't move to one side or the other. Okay. The last thing I'm going to get to do is just say, okay, can you swallow? He can just swallow his own saliva. You don't need to give him anything. Okay. Just see if he can swallow. Watch all the mechanics in his throat, that everything moves symmetrically. Okay, can you stick out your tongue? Okay. Can you say ah? Okay. And then just close your mouth and just swallow for me. Anything feel abnormal when you're swallowing? No? Okay. So I see all the muscles in his throat, a little dry. But you can see him actually, his larynx raises right as he swallows. that everything moves symmetrically. And he'll know if there's some weird feeling there as well. So once we're done there, we're going to go to hearing. Can you repeat the phrase again? You can't teach an old dog new tricks.
You can't teach an old dog new tricks.
Okay. I'm going to do hearing and then muscle resistance. Okay. So I'm just going to rub my fingers together on either side by your ears. You tell me which ear you hear it at. Okay.
Right. Left. Left. Right.
I'm going to get you to just test some muscle strength in your shoulder and neck. I'm going to put my hand on your shoulder and you lift them to the ceiling. Okay, great. Now I'm going to put my hand against your face. I'm going to get you to turn against resistance. Okay, try to turn your head with me stopping you if you don't mind. Okay, same side on the other side. Okay. Now I'm going to get you to put your head down, and I'm going to hold on the back of your head, and you push me back. Okay, push back. Okay, so we're just checking what's his strength there. And we already did his tongue, cranial nerve 12. We already got him to stick at his tongue and look for symmetry already. Okay? So that's cranial nerve assessment, which sounds scary. It's not at all. It just takes some time. Now we're going to do strengths. Remember that you have two types of neurons, right? You have motor and sensory neurons. Does that make sense? You have other types, but anyhow, that innervating extremities. Okay. So we're going to have him. We're going to test some of these things. Usually I'll start from distal, away from the patient, working close to the patient. So I'm going to start with his fingers, then do grips, then chest, biceps, test triceps. Then I'm going to test his feet. Then I'll work up to his quads and his hamstrings and his hip abduction and adduction. Okay, fingers together like so. Spread my thumbs and fingers apart, spread them apart. So we're checking abduction. Squeeze my fingers. Hard. Good. Okay. Make two fists for me. Push me away. Okay. Pull me towards you. Okay. So nice and equal. You're going to come down to his feet. Can you just put my hands on your feet? Push me away. Pull me to you. Okay. Can you just bend your knees? Bend your knees up. Okay. I want you to push my hands into the bed. Push down. Push. Okay. And now I want you to once again. I want you to bend your knees. Now push my hands to the ceiling. Okay, that's more so your quads. Hard to. We really want him to push and do a quad for you, but that's hard. To really test quads, but that's okay. It's not great. It kind of gets up into his hip flexors as well. But we're just testing symmetry. Can you push my hands apart? Push them together. Okay. And that's it for motor. Okay. Then for coordination, which has to do with cerebellum function. So this is your athlete's brain. I don't have a big cerebellum. I'm quite certain if they scanned me because I tend to trip over things and not all that coordinated or whatnot. So, but these involve a number of different functions, motor and coordination, and some involve also like visual fields and stuff like that. So the first one that you can have somebody do is just rapid hand movements. So put their hands, just say, can you touch your palms of your hands to your thighs and the back of your hands? And then just repeat that. Okay? So we want to see that he's not like struggling to do that. Okay? The other, a little bit more detailed, I'm going to get you to reach out and touch my finger and then touch your nose. And then I'm going to move. I'm just going to get you to keep your head straight ahead. I'm going to move over, and you're going to follow with my eyes and keep doing that. Okay? So you touch my finger, touch my nose, and I'm just going to move my finger back and forth. Okay? So we'll start on your right side. Yeah, and touch your nose, and then back, and then back, and one more. Okay? Now we're going to do this hand now. Okay? Same thing. Good. Thank you. So those are some testing of coordination. Now on to sensory function. This is feeling. So we're back to our sharp, dull, and light. It doesn't matter if you wanted to do, some people will do muscle, then sensory, then coordination. I don't care. Okay. So once again, I'm going to touch you with this pin, with the dull aspect and the soft. I'm going to get you to close your eyes, and you're going to tell me where you can see. Just before I get you to close your eyes, on the last page of this, there's a dermatome map. The last page of the neurological targeted history and physical reference sheet. There's this person standing like this. That shows where nerves exit off your different branches at the level of your vertebrae. So that's like T is so cervical, then thoracic, then lumbar, then sacral into the back of the legs. So different regions, okay, of where there's different branches. So the lowest branch, if you're attacked spinal cord, is actually down to anal tone, which seems, so sometimes when they bring really bad traumas in, they'll actually check for anal tone to make sure, okay, if you have anal tone, that means your entire spinal cord is intact, okay? So they go the first, the furthest point down, okay? So when we're going down this, I'm not going to test, you could test every single dermatome as you're going down for sensation. We're not going to do that. I've given you a few, so we're going to hit the big spots. But it's interesting, I just find it interesting every time I look at that. Like you would think hands would be innervated by the exact same point off your spinal cord. But thumbs are C6, whereas pinky fingers are C8, right? Whereas kind of the inside medial aspect of your arm is actually T1. Okay? So different regions where you get innervation. So that's where you can have somebody that's actually classified as a quadriplegic but can move their thumbs a bit, right? So as we're going down here, as we're going down here, we're just going to feel through, we're just going to go ahead and go through and find sensation in different regions, okay? So I'm going to get you to close your eyes. I'm going to touch you, or just set your hands on your thighs. I'm just going to touch your thumb or your thigh or your pinky finger around the inside of your arms, the outside of your arms, and see if you can feel that, both light. I'll start off with light, okay? You tell me which hand I'm touching. Notice any difference from side to side? No? Don't notice any difference in areas that you can feel differently? I should have compared side to sides rather than, I kind of did this, and that's probably not ideal. Just go one area, go to the other side, go one area to the other side, and ask if there's any differences. Now we're going to do the same thing with dull, okay? Let me know if you can feel this, which hand. Let me know if there's any differences, okay? Great. Now we're just going to try with that pin. I'm doing that again.
Right.
Sorry. I'll get this eventually.
Right.
Good thing worth. Okay. Now I'm just going to come down and I do the exact same thing in his feet. I've given you that we're doing sensory. I'm just trying to remember where I told you to go. So we're just doing medial and lateral aspects of the calves, and then front of both sides, and little toe is S1. So we would just do same thing, dull or soft, here, 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 and just here. Okay. Same thing with pin. Sometimes you might find, like, if they have full pants on, I'm probably just going to do feet and extremities. I might not do their thighs, okay? Depending on the situation and how much. So then on to the physical assessment. So with the cranial, so with a neurological assessment, we're missing a few pieces here. We haven't done reflexes, and we haven't done anything with sensory with tuning forks, okay? So there are some aspects that we're not doing with you folks. That would still be included in a full neurological assessment. So this is just shy of a full neurological assessment that you may see a physician do reflex hammer or doing some stuff with tuning forks to see what they sense. But it starts off cranial nerves, motor, then sensory. Now sensory can include not just light touch, dull, and sharp, but also can include temperature. Not always done. The other things that can be included in sensory is position. So with their eyes closed, if you just take body position. So I just say so sensory. Can you which direction do I have your palms up or palms down? Palms up. You can also give them something like really familiar, like a key. Say, close your eyes, I'm just going to give you something, and can you tell me what this is? And they feel it and go, oh, that's a key. Okay. Vibration at each, they do along through. We're not doing this. They usually would go to a kind of major joint areas and look for vibration to see if they're feeling. So they go like big toes and thumbs. It's very similar to see if they're feeling vibration. Not, and I'm not. You won't be doing that because I don't have tune. I don't think it's necessary, and I don't have tuning forks for you. We could get some tuning forks. Then, as far as the physical assessment, it's really quick, right? So I just go, I'm just going to look over your body really quickly after we're done your neurological assessment. Do you see any scars, rashes, lesions? Okay. A note in his mouth, stick out your tongue, see that you're moist or not. We already saw that. I could look at his neck, tracheal line, no JVD, no scars, rashes, and lesions. Take a deep breath for me. Okay. Listen to his lungs 4 times, right? No pain in your abdomen. Push on his belly. Just see if he's in any pain. And just no pain in your legs. Look for swelling, color, movement, sensation in the extremities. So an incredibly skinny physical assessment, right? Like even skinnier than rapid medical assessment, right? Because we've dealt with so much of his neurological system. We'll just kind of grossly look over region by region, just inspect everything, and a little bit auscultation as test and some palpation. I included palpating carotid pulses. You can have in this patient, I should have mentioned carotid pulses, so you can have strokes as a result of narrowing of carotid arteries, so I would take the time to palpate both sides of carotid arteries. If I felt any abnormal vibrations, you could also listen for thrills or bruise. And we'd get a cardiac monitor and 12 leads on this patient because we'd be interested that some arrhythmias can be prone to spit clots out. So if they have like new onset of atrial fibrillation, that would be something worth noting. Let's stop that video and let's see if I can